All right, so today we are going to perform the SFMA test on Max, who's a third try student at Palmer. Max, so the SFMA is just in general for your movement of your body. We're looking at any dysfunctional spots, mobility, or painful spots that might occur while doing these exams, okay? So we're going to start with the SFMA cervical flexion. So we have our patient here, shoes are off, everything's normal, so you can step a little away from the leg. And we're going to have you first, all we're going to do is feet just shoulder width apart, that's perfect. Hands by your side, and you're just gonna look down, try and get that chin to your sternum. So you can see here what we're looking for is a uniform spinal curve, which I see here in the cervical spine. I would label this test dysfunctional because of him not being able to touch his chin to his sternum. You can raise your arm. So that's a perfect example of a dysfunctional patient in cervical flexion for SFMA. Our next one we're going to do is cervical extension. So right where you are, instead of looking down, we're just going to look up at the ceiling. So for this, we're looking for the face to be within 10 degrees of the ceiling, which looks good. A uniform spinal curve, which looks good. Is there any pain with that? No. So I would label that one as functional, non-painful. The next one we are going to perform is a cervical rotation test. So I'm going to have you exactly where you are. And all we're looking to do is turn the head as far as you can to the left. Good. And for this one, we are looking for the nose to reach the mid-clavicular line here, which looks good on the left side. And can we do that on the other side? Good. Can you face the camera for me a little more? Should we try it one more time? Good. So for the right side, I would say it's more dysfunctional due to, it looks to me off the glance that his nose does not meet that mid-clavicular line. Is there any pain with that? Nope. No. So I would label the right side as dysfunctional, non-painful. The next test we're going to perform is the upper extremity pattern 1. So I'm going to have you stand feet together, and all I'm going to have you do is take your arm and reach around and try and touch the inferior angle of your scapula. Just try and touch your other shoulder blade. Good. If you turn around for the camera doing that. Good. So for this one, we see dysfunctional due to him not being able to reach that inferior angle of the scapula. Is there any pain with that? No. No, there's no pain with that, which is good. So we'll have you do the other side. Good. So you can see here the other side looks a lot better. There is some deviation in the wrist, but he's already so high up that I'm not worried about that. It doesn't look like he's torquing or rotating to get extra mobility in order to get that hand to the scapula, which looks good. So the next one we're going to do is the upper extremity pattern 2. So I'm going to have you stand exactly where you were. Good. Back facing the camera. And you're just going to raise one arm and try and get it to the opposite spine of that scapula there. Good. So for this, you can see he reaches the scapula. There's no lumbar lateral bend. There's no torquing of the lumbar spine. You're okay? Is that painful for you? No. No? Not painful, so that looks good. Can we do the other side? Good. So the other side looks good as well. His lumbar spine, thoracic spine, all looks pretty square, uniform spinal curve, along with him touching the other scapula. Is there any pain with that side? Nope. No. Okay, the next exam we're going to do is the SFMA top tier multi-segmental flexion test. So we're going to have you with your shoes off. Good. We are just going to have you stand feet together. And now all I want you to do is try and go down and touch your toes. Good. So what we're looking for here is the uniform spinal curve. We're also looking for a weight shift. It does look like there is a posterior weight shift, which is good. The patient cannot touch their toes, which would signal to me off the bat that this test is dysfunctional. Was there any pain with that? Mm-hmm. No, so it's non-painful. The sacral angle also has to be less than 70 degrees. So can I have you do that one more time for me? Good. So the sacral angle looks to me like it would be more than 70 degrees, which would be another sign that this test is dysfunctional to look at the pelvis area. So the other one we are going to do now is arms together. Watch out for the right. So you're going to put arms together over your head. Good. And now what I want you to do is just bend from your lumbar spine and try and get those hands as far back as you can. Good. Good. You can raise up. Was there any pain with that? No. No. So for this, we're looking for the patient to Yeah, that looked good to me. But we're looking for the patient basically to not have any extra support, not looking to bring the feet back, anything. We're looking for a good uniform spinal curve going backwards, which looks good to me. The next one we are going to do is rotation. So I can have you stand here. Good. Now I want you to just come here and rotate as far as you can with those feet staying the same. Good. So for me here, this looks good. He has 100 degrees of rotation total, 50 degrees from the pelvis and 50 from the torso, which looks good. Was there any pain with that? Can I have you do that on the other side? Good. This side looks a little more restricted to me, but he has a good 50 degrees from the pelvis. Good job from the thoracic spine. So that would look functional, non-painful. Okay, the next one we're gonna do is the single leg stance. I'm gonna have you face the camera. Good, and you can get a little away from the bench here. Good. Now all I'm gonna have you do is your eyes are gonna be open. You're gonna pick a leg and just stand on that and try and hold it for 10 seconds, okay? Okay. So for this, we're looking for any pelvic rotation, any flailing, any shaking. If he can't maintain his balance for 10 seconds, which is up, good job, and other side. Good. Hold it there. No flailing again. We're not looking for any pelvic deviation, which it looks like there is on the left side. Okay, now for this one, we're gonna have you do eyes closed. Go on that right leg and try and hold that for me. 10 seconds. So we can see right away he's just flailing. His pelvis is dropping on one side. So he's recovered, but nope. Okay, so I would say that is dysfunctional. So no pain with that? Okay, other side, eyes closed. Good. So we see it's better on the left side. Still flailing and everything. Okay, can't hold for 10 seconds, so I would say that is dysfunctional. No pain with that? No. No pain with that. Okay, now I'm gonna have you do hands together out front. And all I want you to do is from here, go into a deep squat and hold it, okay? With feet together, sorry. Feet together. Have your feet together. Good. So it looks like thighs break parallel, which is good. Indication that this is a functional test. Can you put your fists to the floor, the back of your hands to the floor if you do that one more time for me? His heels are staying off the floor, which is another sign that this test is functional. Can you put them to the floor like this and hold it? Good. So you can put his hands to the floor, hold it. This looks like a functional test. Was there any pain with that? No. No pain with that? Good. Okay, and that is all for the SFMA. Go. Okay, today we're going to do the gait assessment on Max here, who's a third try student. So Max, we are looking for a couple of things. Max is going to start walking in a second, but we're going to look for things like arm swing, pelvic, posterior rotation, hip flexion extension, internal rotation, external rotation. For the knee, we're looking for varus or valgus stress mostly. We're also looking for knee flexion and extension. We're going to look for foot flare, ankle dorsiflexion, subtalar joint, midfoot and forefoot, and first metatarsal phalange dorsiflexion. Okay, Max, so why don't you go ahead and walk. So right off the bat, I noticed a lack of arm swing that he has, or arm sway. He's very stagnant with his arms. In the pelvis area, it looks to me that the right pelvis is going to have a bigger pelvic lift. So if you watch that translation as it drops down on the right side, I would categorize that dysfunctional due to it being over 1 inch. For the hip, the internal and external rotation looks good. To me, it looks to me like the left hip is kind of more stuck as far as rotation wise, where the right hip is carrying majority of the load. As we work our way down to the knee, we're gonna especially look at that left knee going varus, while the right, if you go down, the knee flexion extension looks good. If we're gonna look at the right knee, it's gonna pronate a little more inside than the left, if you see that internal rotation there. As he's walking. As far as his foot flare, it looks good. It looks like he doesn't have any foot flare. Feet are kind of moving along that line. For ankle dorsiflexion, I noticed that the left foot, if you watch the left foot, it doesn't dorsiflex as much and it feels like it's more carrying out. Just a tiny bit. It's not a flare, but it's definitely not fully getting to that degree that we needed to get to. For the subtalar joint, I noticed that the right side, it just looks like, again, going on with that varus knee, that subtalar joint is taking a lot of pronation in the joint and a lot of stress on that medial side. As we work our way towards the midfoot, I noticed that the right side is going to be more stuck on him as far as not pressing off the ground and getting to that extension. His first metatarsal phalange dorsiflexion looks solid to me. Maybe the right side a little bit less, but yeah. So overall, that would be our walking and gait assessment for Max.
So I'm going to perform the cervical flexion rotation test this time, and this test is basically showing the assessment for C1 and C2 dysfunctions. And this test shows that C1, C2 region isolated with the flexion of the lower cervical region. And this also allowing us to see the rotation in this C1 and C2 region. So first, I'll let the patient supine lie down on the table, and I'm going to flex the patient's neck, and then I'm going to turn to the one side. Good. And to the other side. Good. So I am able to see that the patient's head rotates more than 40 degrees, which is functional. And did you have any pain with that?
Nope.
Max? Okay. So I would say functional, no pain. So what is that? Functional,
Non-painful.
non-pain.
Yeah.
Yes. Okay, so I'm here with Max again. This time we're gonna do the wall angle test. And the purpose of this test is to see the patient's ability to maintain upright posture and mobility of their thoracic spine and lumbar spine, ribs, and shoulders. Okay, so I'll have you stand a few inches off of the wall. Okay, and okay, I think you step a little further. Yeah, that's good. And I'll have your arms like 90 degrees. Okay, and try to maintain all your fingers on the wall. Good. Then back of your head and thoracic spine and glutes in contact. Make sure you make the contact with the wall. Okay, that's good. Alright. And you're directly looking forward. Okay. Alright. I couldn't see the maintaining the contact of all the fingers against the wall. And okay. Yeah, so that would be the dysfunctional movement. And his head stays in horizontal. That's good. Yeah.
Hello, we are here again with Max. We are going to perform a seated thoracic rotation test on him. So for this, we're looking at thoracic mobility through, and we're looking at thoracic mobility while taking out pelvic rotation, okay, to see the true rotation of his thoracic spine. So we're gonna have you sit down, knees and feet together for me, sit tall. And we're gonna have you cross the right leg over. So not all the way over, but just, yeah, right there. Perfect. We're gonna have you put that there. And now we are going to have you rotate to the right. Put your hands up here. And we're gonna have you from there, just rotate to the right. Good. So Max here, it looks dysfunctional to me off the bat due to him not being able to reach 50 degrees of rotation in the thoracic spine. Is there any pain with that?
Nope.
Okay, I'll have you uncross your legs, go to the, recross them, other side, left over right, good. And now you're going to rotate to the left, hands up again, good. Good, rotate there. So he looks a little better this side. He's almost at 50, not really, which would indicate a dysfunctional test for me. And because he's dysfunctional in this, we are gonna have him go to a lumbar locked extension / rotation test. So I can have you go on the table just like this for me. I can show you, you can stand up for a second. So I'll have you just go in like a child's pose almost here. Okay, and then from here we're going to take one arm, place it behind here, and then rotate up, okay? So see if you can remember that, I can help you out. So let's start with that left side. So we're gonna have you child's pose, good. You can put your forearm down, good. This behind the back. And from there, I want you to rotate up. Good. So for this one, we're looking for 50 degrees of rotation, which is almost there. He has a dysfunction in his thoracic, in thoracic mobility. He's dysfunctional in that. I'm gonna see if I can actively get him there with rotation, so I'll have you go back there. Good, and I'm just gonna push a little farther. Any pain with that?
No.
No? Good, so from here actively, we've gotten him to 50 with no pain, which is good. So we can see that this is just a mobility problem, which will be good. And we kind of do the other side as well. Good, so try and get there all the way. Good, we'll have this more so you can come back for me. Good, right there, get up. So he's almost at 50 again here, not quite. Can I actively push here? How's that?
Good.
Good, so now we got him to 50, which looks good. So we've indicated that this is just a passive problem for him. There's no pain, so I can actively get him to 50, so that's something we're gonna have to work on him with. Okay, so here we are going to perform the hip extension motor pattern test. The purpose of this test is to see the correct order of activation and speed of contraction during the prone hip extension test. So we're gonna have the patient lock the leg at the knee, and all I'm gonna have you do is just lift that leg up straight. So can you do that for me really quick? Good, perfect. So you can put it down. And now I'm just gonna put my hands here. What I'm looking for is the spinal extensors to fire, ipsilateral extensors to fire. Quality of glute control is crucial for this test. So we're looking for those in the order of contraction and the overall shakiness or smoothness of the movement of the leg going up. So I'm gonna have you, same thing, lock out at the knee and raise up for me. Good, so I feel the spinal extensors and the ipsilateral extensors moving. The foot and overall feel does look shaky. It looks to me like the ipsilateral glute is firing. So that order looks correct. However, the leg is shaking at the top, which would indicate a instability somewhere, either in the lumbar spine or glutes or hamstring muscles. So I'll have you do that same test on the other side. So we're gonna lock out at the knee, come in here, good. So for this one, feels weaker. Ipsilateral extensors feel weaker to me, like they're trying harder to fire, but it's not getting there. The glute looks activated. The leg is shaking as well, so I would label this dysfunctional because of that. But definitely the ipsilateral extensors and spinal extensors on him were dysfunctional. So now we're gonna have you flip over. I'm gonna have you flip over on your side, good, and we're just gonna do the hip abduction motor control. So I'm gonna have you do is raise your leg straight again, like lock it out, good, perfect, like that. And we're just gonna have you raise it up, you can lay it down. So you'll slowly raise it to the top as high as you can. And we're looking for anterior, posterior drift or any hip rotation during this. We're making sure that it reaches over 45 degrees of hip abduction. As well. Okay, so I'm gonna have you slowly again lock it out and slowly raise it as high as you can. So it looks to me like there is 45 degrees of hip abduction. There is a little drift posteriorly of the hip Internal, external rotation of the hip looks good. You can go ahead and lower your leg. The leg was drifting a little anterior, which would indicate the IT band weakness. So that's another thing to look forward to as you roll over on your other side and perform that exactly as well. So once again, we are looking for more than 45 degree of hip abduction. We are looking for that posterior anterior shift, so we can see the leg coming forward a lot on this right side, which would indicate the tight IT band as well. He doesn't get this leg as high up, which would also indicate an instability in the hip. The posterior, there was anterior drift and anterior rotation of the pelvis as well. So I'll keep that in the correlation, but so far I would claim both of these tests as dysfunctional. Was there any pain with that?
No.
Dysfunctional, non-painful.